Hi, let's continue the clinical series. This is part 3. So, today we are going to see two important bottom cases. So, the first one is, as you can see here, there is a picture which shows postoperative status of a flap based procedure for pilonidal sinus. So, the first question is, what is the name of this flap? It's a very important flap which is nothing but a transposition flap. So, the name of the flap is Limburg flap. Limburg. Okay, right. What is the difference between sinus and a fistula? So it's a very basic difference you need to understand. Sinus is something, both are tubular tracts. Sinus is something like a one end of the tube will be open onto the surface and the other end will be blind. Whereas fistula is nothing but a it's like a flute. So it is an abnormal tubular connection between two epithelial surface, and the basic difference is both sides are open. So this is a fistula and this is a sinus. Okay, right. Next. So this condition is also called jeep disease because it is more common. This pilonidal sinus or pilonidal disease is more common in those occupations with prolonged sitting. Okay, so this condition is also called jeep disease. And in which position, in which occupations it is more prone means anything which is related to prolonged sitting, like usually seen in drivers or even in case of very rarely software employees, whatever profession that is related to prolonged sitting. Okay, right. Next, what are the other named surgical procedures for this condition? So we need to understand the treatment options for pilonidal sinus can be categorized as something like, if it is something like a full of abscess and all, obviously you cannot close the wound with the flap. So in such conditions, you will just excise the disease and you will keep it open. That is called primary excision, or something like a keeping it open means laying of the wound. So this is something like a primary excision. That is one option. Okay, nothing but keeping it open. So excision plus keeping the wound open. Right? Now, second one is something like a you will remove that sinus part and you will close the wound with some reconstruction procedure. Nothing but usually we will use for flap. Okay, right. So the common flap based procedures are, one is, as we have seen, Limburg flap. Then second one is Bascom's procedure. Third one is carry Daki procedure. Okay. So what is the basic difference between Bascoms and Karadakis? First, let's look at Karadaki. So this one is a Karadaki. Okay. So what is being done here? As you can see, usually, whenever there is a midline disease, we will go lateral to the midline. As you can see here, we are making a lateral incision here. Lateral incision, and you are removing the entire disease, and you are moving a contralateral flap. As you can see here, this is a contralateral flap, and you are closing it just lateral to the midline. Okay, closure is paramedian. Right, this is about Kataki. Now, what is Bascom's? Here also you are making a lateral incision, but instead of closing it, you are removing all the sinus tract. So here also you are going for lateral incision. Okay, right. So this is the lateral incision we are making, and you are removing the entire sinus tract which is present in the midline. Okay, right. Then coming to the second case scenario. So a 45 years male patient presents with complaints of painless bleeding during defecation and mass protruding per rectum. Digital rectal examination revealed hemorrhoids. Okay, So first question, what are hemorrhoids? So you need to understand there are basic cushion-like things. So see, you have got cushion-like things which are nothing but your venous channels. So whenever that venous channels of the anorectum are dilated abnormally, they are called hemorrhoids. Okay, so there is nothing but dilated venous channels of anorectum. Okay, right. So what are the types of hemorrhoids based on dentate line? So you know 2 centimeter from the anal verge, there is a line called dentate line. Okay. So based on this dentate line, what are the types of hemorrhoids? Let's say for example, you are having hemorrhoids originating above the dentate line. In such case, it is called internal hemorrhoids. Okay, right. Let's say for example, if the hemorrhoid is originating below the dentate line, they are called external hemorrhoids. These are the two types of hemorrhoids based on dentate line. Now, what are the primary and secondary sites of hemorrhoids? So let's say for example, the patient is lying in a lithotomy position, and this is the anorectum you are having. So whenever you see in lithotomy position, so this is the 3 o'clock position, 12, 6, and 9. So there are two important sites of hemorrhoids based on the clock positions. If hemorrhoids are present at 3 o'clock, 7 o'clock, 11 o'clock. So these are the three important clock positions where these are called primary hemorrhoids. Okay. Apart from these three clock positions, at whatever clock position, if hemorrhoids occur, they are called secondary hemorrhoids. Okay, right. Next, so grading of piles. So what is the basic grading of piles means? So you need to understand what is the basic complaint the patient is coming to you whenever he is having hemorrhoids, bleeding per rectum. Second one is mass per rectum. So based on these two important clinical features, hemorrhoids have been classified into four categories. So you can easily understand class, then bleeding, mass, mass per rectum. Okay, right. Only bleeding present, no mass. This is your first class or grade 1 hemorrhoids. Okay, right. Next, bleeding may or may not present. Mass is present but spontaneously reducible. So patient says, doctor, I feel something is coming out of the rectum whenever I am going for passing the stools, and it goes inside by its own without any manipulation. So spontaneously reducible. That is class 2 or grade 2. Right? Next. So patient said there may or may not be bleeding. There is mass per rectum which is present and it is reducible with only manipulation. Only with the manipulation. Like digitally, the patient has to push it inside. Right? Next. So this is class 3 or grade 3. Next. Bleeding may or may not be present. The mass which has been protruded through the rectum is permanently prolapsed. So that is class 4. So permanently prolapsed hemorrhoids. That is class 4 or grade 4. So this is the important classification of hemorrhoids, grading of hemorrhoids. All right, next. So what are the important complications of hemorrhoids? So you need to understand whenever there is a huge mass per rectum which is sitting there, what are all the anticipated complications you can expect. So whenever there are mass per rectum that is something like present like this, what are all the things which can happen? So one, it can undergo strangulation. So the first one is strangulation. Then it can undergo thrombosis. Whatever the venous channel, it is a venous channel now, the blood can get clotted and it itself can got thrombosed. So second one is thrombosis. Then the apical part of this hemorrhoid can get ulcerated, or even it can undergo gangrene. Next, rarely at a last stage, something like that, it can undergo fibrosis. One important complication that what you need to understand is whenever there is a secondary infection going on at the level of hemorrhoids, what happens ultimately where it is draining into portal vein. So whenever there is an infection present here, it can cause portal pyemia. It is an important complication where the infection is traveling through the portal vein and it will cause portal pyemia. Okay, and even sepsis also. Okay, so this is a dreadful complication. These are the important complications of hemorrhoids. Right? Next, what are the important treatment options for hemorrhoids? So, why are we studying about grading or classification? Grading of the piles basically means so depending upon the grade of the hemorrhoid, you can treat it accordingly. So, first and second degree hemorrhoids usually we will treat conservatively. Like what are the important things? The main predisposing factor for hemorrhoids is constipation. So you need to advise the patient to avoid constipation by taking high fiber diet and plenty of oral fluids. And the patient should avoid high carbohydrate and low fiber diet. And we will usually give prophylactic antibiotics, anti-inflammatory drugs, and to soften the stool, we will give laxative syrup. And the most important thing is sitz bath. So we will ask the patient to sit in a tub of lukewarm water for around 10 to 15 minutes, BD or PID, for around 5 to 7 days. So, sitz bath is very important for all the bottom cases fissure, fistula, hemorrhoids. Now, apart from this, like medical usually will go for broad spectrum antibiotics, PPI, analgesic. Usually, hemorrhoids are painless, but if it is something like which are arising below the dentate line, because you know that the area which is present below the dentate line is very painful. So in such condition, it will be painful. Then you will give analgesics, then anti-inflammatory drugs, and very rarely, let's say for example, if the patient is not responding to your conservative treatment, then you can go for OP-based procedures. So what are the important OP-based procedure means? One is banding. So second one is sclerotherapy. What are you trying to do here basically? So, what is banding? So, wherever you have that hemorrhoid, you will apply a rub band like this so that it will undergo ischemia and necrosis and slowly it will slough off. So, that is called banding. Otherwise, you can go and inject a sclerosing agent here. So, what are the important sclerotherapy agents you are using? So, one is sodium tetradecyl sulfate, and you can also use polydocanol. Okay, so these are the important sclerotherapy agents we will use to inject into the base of the hemorrhoid. Again, the mechanism is same. So the intima will get fibrosed and it will undergo ischemia and the hemorrhoid will fall off by sloughing off. Okay, right. So let's say, for example, if they are not resolving even with the OP-based process or even conservative treatment, then you can go for surgery, right? So what are the important surgical options which are usually adopted for third and fourth degree hemorrhoids? It is nothing but you will remove the hemorrhoid by excising it and removing it. It is called hemorrhoidectomy. So what are the important types of hemorrhoidectomy? So you can remember one is open hemorrhoidectomy, second one is closed hemorrhoidectomy. Then it is something like you can use even laser also. So laser hemorrhoidectomy. What is the basic difference between open hemorrhoidectomy and closed hemorrhoidectomy? So whenever you are dealing with the hemorrhoids, so you will just remove it and you will leave the wound open. So once you excise the hemorrhoids, it is something like the picture will be something like this. So in old edition of Bailey, there used to be one line: "If you see clover, the problem is over." So you will leave it open. The wound is left open. That is why it is called open hemorrhoidectomy. What is the name of this operation? Milligan Morgan operation. Milligan Morgan hemorrhoidectomy. Okay. Now, closed hemorrhoidectomy goes by the name Ferguson. Ferguson hemorrhoidectomy. So what is the basic difference between open and closed? Here, the wound is not left open. Once you remove the hemorrhoid, the wound is closed here. So after that, it will be something like a, you will suture the wound like this. So that is called closed hemorrhoidectomy. After excising the hemorrhoid, you are closing the wound by suturing it. That is called closed hemorrhoidectomy. You are just using the laser energy to excise the hemorrhoid. That is called laser hemorrhoidectomy. Then there is another important procedure called PPH. It is also one type of hemorrhoidectomy where it is called procedure for prolapsed hemorrhoids. So usually only for internal hemorrhoids this procedure is done. So procedure for prolapsed hemorrhoids. This is nothing but stapler hemorrhoidectomy, where with the help of a circular stapler, so it will be something like there will be a circular stapler. So you will just use the circular stapler to remove or excise the hemorrhoids which are only internal. So you will apply the stapler and you will just fire it. So you are removing the hemorrhoid along with the bit of a mucosa. Okay, so that is stapler hemorrhoidectomy. It is done only for internal hemorrhoids. Internal hemorrhoids. All right, right. Next. Last one is, it's a very advanced procedure where it's not that commonly done. The name is HAL. So it is nothing but hemorrhoidal artery ligation. What do you mean by that? See, basically, this large venous channel will be supplied by a some other blood vessel. So you are just whatever the blood vessel that is supplying to the large pile, using an ultrasound Doppler, you will go there and you will just ligate that blood vessel or artery which is supplying the hemorrhoid. So that is called hemorrhoidal artery ligation. Okay. So these are the basic treatment options for hemorrhoids. Thank you.